I'm talking about a little bit delayed complications of a heart attack, right? So when we talk about heart attack, either it is a partial heart attack, or you can call it as an STEMI or a STEMI, or a transmural heart attack, right? So, in your opinion, and we'll just have a chat in between. If you have any questions, just stop me. But could anybody tell me what are the delayed complications that can happen after a transmural heart attack? There are three major complications that can happen. And they usually happen anywhere from maybe 36 hours to maybe within 2 weeks. So those three complications are, one, it can be a free wall rupture of the ventricle. Second, that can happen is septal rupture, or called as a post-infarct VSD. And third complication that can happen is a severe acute MR, probably due to rupture of the papillary muscle. And we see all of these three things not so commonly as we used to see it long time back, especially due to all that 90-minute time and the patients coming in early and being treated in the cath lab. But still, these are quite lethal complications that we have on and off. And some of you might have taken, Morgan, you did take care of one of my lady who actually unfortunately passed away this morning, post-infarct VSD. So what we'll do is we'll quickly go over all of these things. While I do that, what I want to do was, I wanted to pass this on to you guys. Open this up and see, maybe you guys can come closer. So before we talk about all that, we need to see, everybody knows anatomy, but, right atrium, left, right ventricle. And I just open this up. See, what you have to appreciate here is, in everybody's heart, how these valves and the septum and the wall, they're so interconnected and so close to each other. That is the key to understand these things. So let us first talk about this one. Let's talk about post-infarct VSD, and then we can go and talk about those two things. You can pass this around if you want, but yeah. So post-infarct VSD. So VSD is nothing but ventricular septal defect. It can be congenital or it can be acquired. When we're talking about congenital septal defects, it's one of the commonest. Happens in 4 in 1,000 kids that are born, and is actually the second most commonest congenital defect. Does anybody know which is the most common congenital defect by any chance? It's a bicuspid aortic valve. So 1 out of 10 people, if there are 10 of us here, 1 of us has a bicuspid valve. So 1 out of 10 people have a bicuspid valve. We can talk more about bicuspid later, but if coming back to VSD, it happens in 4 out of 1,000 kids. Can be either in the muscle. You see that in the septum there. Septum can have a muscular part, or it can have a membranous part right here. This is the muscular part, and right below the valves is the membranous part. So that septal defect can be either in the membranous part or it can be in the muscular part. And 70% of the times in the kids, that VSD closes by approximately 2 years. And it can be a small VSD that may not have any impact on hemodynamics. It can be a medium or a large size VSD. If it causes symptoms and stays open, then obviously it needs treatment plans. Without going further into details about the congenital stuff, let's get back to the acquired VSDs. So when somebody has a major heart attack, now it can be either an occlusion of his LAD or occlusion of his posterior descending artery, branch of right coronary artery. All of these things can lead to VSDs. There are different kinds. So if this, say for example, if this is the inlet where the mitral valve is, and say if this is the septum, it can be either anterior, it can be posterior, it can be in the basal part. So VSDs can happen anywhere. But the key to remember is, usually they happen in diabetics, right? They're not feeling the pain, and it goes on, and they have a major heart attack, and they come in usually maybe anywhere history from 3 days to a couple of weeks since they have had not been feeling well, having those symptoms. And what symptoms do you think they come in with? Just based on symptoms, it's very difficult to diagnose a VSD. Like, you know, same thing, some people with chest pain, mostly shortness of breath as the VSD is getting larger. And then when they come in, show up at the hospital, they're hypotensive, they're in cardiogenic shock. Why is there a cardiogenic shock, you think? What happens in a VSD? Can anybody tell me? This is not an interrogation. We just say something and then, it might be wrong, so what?
The flow.
Flow, right? Correct. For the flow, you have to have higher pressures and lower pressures. The pressure on the left side is higher than the pressure on the right side. So what will happen to the flow? Does the flow go from the left to the right or right to the left, you think, when there is a VSD?
Left to right.
Left to the right, yes. So then what happens? All the flow from the left ventricle goes into the right ventricle. And then if say, just arbitrarily, if say 200 ml of blood is coming from the left atrium into the left ventricle, and say 80-90 ml is going to the right ventricle, obviously less amount of blood is going to the aorta, right? So that's why your blood pressure is low. And then when the blood pressure is low, that is cardiogenic shock, right? And what happens to the right heart? Right heart has a very thin muscle. It can only tolerate so much pressure. It can only tolerate so much volume. It starts getting bigger and it starts getting weaker. Right heart failure. When it starts getting weaker, what is going to happen? It's not going to push in all that amount of blood into the PA and into the lungs. So then this is a vicious cycle, right? First, from the LV, not much blood is going to the body, so that is systemic hypotension. And from the RV, as it is getting tired, it's not going to push all the blood, so your preload on the left heart is decreased. So this is how the vicious cycle starts. So obviously they're presenting with low blood pressures. Kidneys are, all the multi-organ failure is going to develop, right? Kidneys are not seeing that preload. The gut is not seeing it. If somebody in peripheral vascular disease, they're going to not have blood supply to the legs. So all of those things are going to happen. They're going to have reduced mentation. So that's how you have to think about when they're presenting with cardiogenic shock. Those are the symptoms. Now, what signs do you think they would have? Can anybody tell? And there's a murmur. Any heart, valvular disease, structural heart disease, there'll be a murmur. What kind of murmur do you think? It's a harsh murmur. You put your stethoscope in, you can tell it's a holosystolic murmur. It's just, you just see it constantly. So it's that's the sort of murmur you think. And then what modalities do you think we need to do to diagnose a VSD? Somebody comes in cardiogenic shock. Yes, what do we do? We get an EKG, right? Next, what do we do? Echocardiogram, right? Echo is the key. So in transthoracic echo, you can usually pick up the VSD very well, and you can see it. So now, say we have done a TTE. Now for a TEE, difference between TTE and TEE. TEE, yes, we see it better, we see the location better, and we can do measurements. And then following that, we do a cardiac MRI sometimes. Why do we see a cardiac MRI? Again, to see the location. As I was pointing out to you, the proximity of the mitral valve, the proximity of the apex, and the proximity of the tricuspid valve. So we want to see where the location is so that we can plan for a treatment. Now, there is one more thing that you could do, maybe by putting a Swan-Ganz catheter. What can you see on a Swan-Ganz catheter that will tell you, that will confirm that there is a VSD? Can anybody tell me?
Mixed venous.
Mixed venous, right. So what happens is, what do you think the saturation, in a normal person, what do you think the saturations will be in the right ventricle?
I don't know that.
I mean, not percentage, they'll be low, right? It's a venous blood. But now, if you see blood, coming from the left ventricle to the right ventricle, your oxygen saturations will be high. There'll be a step up that confirms a VSD. So we can do that, but now since we have TE and all, when we can see it, there is no reason to do that. That's why we don't do that. Okay, so somebody has shown up and now has a VSD confirmed. What do we do? What can we do in the immediate period? What can we do in the latter period? Immediately we have to stabilize the patient, right? The VSD has happened because the blood supply to the septum is gone and it's become infarcted. When an infarcted muscle is nothing but like cheese, that's what it is. It's going to disintegrate. So imagine putting stitches through that. They just don't hold stitches. That's why there have been a lot of studies. Basically, if the patient may be kept hemodynamically okay, either by reducing the after. How do you do that? We can give vasodilators so that if the afterload is less, then the forward flow can be higher, and the shunt across the left ventricle to the right ventricle reduces. We can do that. But sometimes, if the patient is struggling, what do? You put them on a balloon pump. Right? You put them on a balloon pump. Then what does the balloon pump do? Obviously, increases the coronary supply and reduces afterload. That way, the LV can pump all that blood more towards the systemic vasculature than going into the RV. So we do all this temporizing measures. And when we make a decision to operate, say if patient doesn't have multi-organ failure, it is better to wait. Better to wait until those, infarcted tissues heal a little bit. Those infarcted tissues, and that hole that we talk about, I might draw a hole like this. It's never a hole like this. It's a very irregular hole, and sometimes imagine this is a muscle, right? It can't be just a single hole. It's a serpiginous hole. You'll see a hole. It's very obscure. It's not very clear where the margins are. So we want all of that to heal, so that when we go and repair it, it has good edges, strong edges, which will hold, which will give a better chance of healing. That's why we like to wait if we can. So sometimes what we can do is, if the patients are really struggling, we can put them on ECMO. We put them on ECMO, and we decompress the ventricle, support the organ systems, and let it heal. Maybe 2 weeks, maybe 3 weeks. The longer you wait, the better chances that septum is going to be healed, and the better chances that septum is going to hold sutures. So we wait. If you remember our patient, she had come in with a heart attack. She was doing okay. We waited for 3 weeks, and we took her. How do we repair these things? So we repair by putting patches in. There are different ways to repair it. Basically, if there is a connection, we put a large patch like this, and then we put like placeted sutures on the periphery of that patch. So once we have this occluded completely, how do we do it? We have to make a big incision either in the left ventricle or the right ventricle. We go in from the left side, or sometimes it can be repaired to the tricuspid valve too. But to really take a look at it in a better way, you could fix it well, you may have to make a left ventriculotomy. So we patched the septum first. We did that for Maxine. We opened up the left ventricle. We put a large, in her case it was different. We thought it was a single hole. We actually found 3 holes in her. It was like a mesh, that's what it was. And still after 3 weeks, it was pink infarcted tissue. So that is a problem we get into. And then we're trying to put a big patch, and it's close to the mitral valve. You can't snag a chordae. It will lead to different problems. It will lead to severe hemorrhage. So those are the things that we get into. Anyway, we put a patch there, and while coming out, we repaired her aneurysm as well. So we repair that, and then obviously it's the same post-operative course as we do for our post-cardiotomy patients. So that is post-infarct VSD in short. Questions I can answer about post-infarct VSD from what I just told?
Where does the Impella play a role in?
Very good. Yeah. If you have a program where you can put an Impella in, at the end of the day, it is decompressing the ventricle, number one, and also it is providing forward flow to your organ systems. So yeah, you can place an Impella as well. But if you compare an Impella to an ECMO, the more you decompress the left ventricle, the better it is going to be. So Impella does play a role too, and we can for sure put an Impella.
So more desirable than a balloon pump, but less desirable than ECMO.
Yes, that's what I would say. At least at the moment. And I think the ease of putting an Impella is better, right? So Impella will definitely play a role in my opinion. More questions I can answer would be okay.
Right.
Then we'll quickly go on to this free wall rupture. So free wall rupture can present, in different ways. Either it can be complete immediate blowout. We can't save the patient. Patient develops pericardial tamponade and doesn't even show up to the hospital. One possibility. The other possibility is it becomes weak and starts to tear and becomes a pseudoaneurysm, or or a clot forms. Patient presents in, again, same stuff: hypotension, short of breath, chest pain. How do we diagnose? Echocardiograms or CT scans, and then obviously we do the CAT, and then that complication of a post infarction, free wall rupture, you cannot wait there. Basically, the muscle is gone. You have to take them. You do the same thing. Put a balloon pump in. You take them, and then what you do is, for example, if this is you, sometimes we take the infarcted tissue out. And if say if this is a hole, I wish I could clean this a little better.
Can I get a wet?
So how do we repair that? Is, say for example, if this is a infart. Say what?
Nothing.
So basically, what we do is, we put a felt here, felt patch here, and felt patch on the other side, and then we repair this in multiple ways. Get them together and put some bioglue and hope for it that it holds. That is free wall rupture. Free wall rupture can happen on the right ventricle, it can happen on the left ventricle, it can happen anteriorly, it can happen posteriorly. But if you compare the free wall rupture to the post-infarct VSD, here you probably have some time for it to heal. Here you don't. It's an emergency. You go in and you have to get that repaired. So that's a free wall rupture. The other post-infarct, complication that can happen is acute MR. Why does acute MR happen? In the LV, there are two muscles, right, which are holding the mitral valve. The mitral valve, if you've seen that, in the heart over there, the leaflets are attached to the muscle by chordae, and those chordae get attached to two muscles, which are, just imagine, one is called as anterolateral muscle, and the other is called as a posterior medial muscle, right? So the posterior medial muscle gets blood supply by posterior descending artery. The anterolateral muscle has blood supply from left anterior descending artery and circumflex coronary arteries. That is an important thing to remember. Why? I'll tell you in a moment. So what happens is, if somebody has an acute occlusion of the posterior medial muscle due to PDA, because the single blood supply, the risk of that rupturing is higher than the anterolateral because it has a dual blood supply. If you lose LAD, you get supply from the circumflex. If you lose circumflex, you have supply from LAD. So how do they present? They again present with having a STEMI, but most importantly, acute fluid heart failure, sudden severe MR. Our body can tolerate MR if it is chronic. If it's slowly happening, our body can tolerate it. But snap, if it just, the papillary muscle ruptures, it's wide open MR, severe cardiogenic shock, and there's no forward flow at all. Everything is going back, and the lungs have become like a sponge dipped in water, basically. Again, for those patients, we put them in balloon pump and operate on them right away. So again, we don't see them as much, but basically what do? Very rarely we are able to repair them. There are different repair techniques, to put the papillary muscle together, but most of the times it ends up being replacement of the mitral valve, and post-operative care is pretty much the same after that. But mind you, all these patients, they're much more sicker than our normal coronary patients, cabbage or valve patients. So that is what we have to remember about. But if you think about the mortality for these, like for VSD, if you don't treat them, about 60 to 70% of those patients die within 2 months. And if you treat them, it comes down to post-repair, there is a mortality about 30 to 32%. So it's a high mortality problem. That's why you got to jump on it and make them as stable as possible, as ready as possible for the surgery. And then it's a one-shot deal. Hopefully that will work. What happened to Maxine? We put a patch in, and then we went all the way as much as possible to the normal tissue. She did fine for a week, doing fine, and then the patch started to disintegrate, probably started tearing, probably continuing infarct, and the muscle started to tear from the edge. So unfortunately, she went back to where she was. So that's what happened to her. So in short, these are the three major post-infarct complications that happen, delayed complications. And when they happen, they're very lethal. In some, they need surgery right away. One, and this one here right away. In this one, we have a chance to wait if the patient stays here. So that's about it.